Good evening, everyone. I would like to extend a warm welcome to all of you. Thank you for joining us for this important discussion. My name is Amy Elliott, and I am a member of Columbia's Women's Healthcare Council, and I'm delighted to host today's Wine Gyn event. Wine Gyn is a series of intimate conversations on comprehensive women's healthcare led by Columbia's top experts. It has become one of the Council's signature events. Today, we will hear from three of Columbia's expert physicians about a topic that is important to many of us: fertility preservation, egg freezing, and reproductive health. We are joined by three of Columbia's esteemed physicians who are at the forefront of this field. I'd like to thank my fellow council members for joining us today, and also a special thank you to my colleagues here at UBS for attending. I invite you to learn more about the Women's Healthcare Council's work. We are a group of advocates that have a strong interest in women's health and support the department's work to advance clinical, research, and education endeavors at Columbia. We will share contact information in the chat box, so please reach out if you'd like to know more about how you can get involved. Before we get started, I hope that everybody is sitting comfortably with a glass of wine or your favorite beverage in hand. I have my ginger tea here. I am pleased to introduce our moderator, Dr. Mary Dalton. Mary is the chair of the Department of Obstetrics and Gynecology and the Willard C. Rapalli Professor of Obstetrics and Gynecology at Columbia University Vagelos College of Physicians and Surgeons. I have a special place in my heart for Mary and her team. As a council member, I continue to be impressed with the department's efforts to advance women's health. And from a personal perspective, the Columbia team cared for me through 3 high-risk pregnancies, which I am eternally grateful for. Mary, I will turn it over to you to introduce our panel.
Great, Amy. Thanks very, very much for hosting us this evening. And thanks so much for all you do for us on the Women's Healthcare Council, being such a great partner, you and UBS, and so many of your team that I've met at UBS when we did seminars there. And of course, to my own team who will speak today. And I think that many of you know on this webinar this afternoon that infertility is a major topic in women's health, and it brings with it a tremendous amount of anxiety, a tremendous amount of uncertainty. And today we're going to have 2 of our doctors, Dr. Jenna Turocy and Dr. Paula Brady, 2 of our wonderful specialists in reproductive endocrinology and infertility, discuss testing and then discuss various options in infertility and especially egg freezing. And then Catherine Monk, who I know has been on this webinar before, will speak more about the mental aspects and taking care of mental health during this time that is so very, very important. So then following the panel, you will all have an opportunity to send us some questions and have our panelists answer those questions. And please feel free to put them in the chat, and we will answer them. We'll get through as many as we can in the time that we're allotted. So without further ado, I'd like to introduce our first speaker, Dr. Jenna Turocy, and she is one of the wonderful members of our infertility group, Columbia Infertility and Columbia Fertility, sorry, because we aim to produce life. And she's an assistant professor of obstetrics and gynecology at Columbia, and she's going to provide an overview of fertility testing. Jenna did her fellowship with us. She did her residency at Harvard Medical School, and we're just delighted to have her here. So, Jenna, thank you very much for giving us your insights on testing this afternoon.
Of course. Thanks, guys. Thanks, Mary. Yeah, I'm really excited to be here with you guys. Makes me excited to see those participant numbers, like how about the high number of you guys. So I'm excited to talk to you guys today. And definitely like questions that you have, this is all for you. So definitely write them in the chat. We'll try to get to them all at the end. I'm going to share my screen. So hold on. Okay, so you guys can see my screen okay? All right. So I figured I would start this off with just like the general, like, when do you see somebody like me? When should you be talking about to a fertility specialist? The two big groups are if you're trying to have a baby and having a hard time, or if you're not ready to have a baby yet, but fertility is really important to you. So those are the two main groups of people that I see. As far as trying to have a baby, what I've learned in this is how hard it really is sometimes to have a baby. Like, we're taught in high school and sex ed class, have sex once, you're going to have a baby. And sometimes that happens, and that might happen more often in high school. But in reality, it's actually really hard to have a baby. Human reproduction is just very inefficient. So sometimes it really just takes time. So usually we say try for a year before we consider you giving the definition of infertility. But you're going to hear us say over and over again tonight how much age matters in all of this. So if you're over the age of 35, if you were trying to have a baby and it's been 6 months and you haven't had any luck, come to see a specialist. If you're over the age of 40, don't wait. We know it's harder from there. But there are other times you don't even need to wait for that. Like, if your periods are irregular, you don't know when you're ovulating, you don't know when to have sex, don't feel like you need to wait. That's the time to go see a specialist. Or maybe you've been diagnosed with something like PCOS, endometriosis, maybe you're worried about fibroids. Definitely don't feel like you have to be waiting like a full year to talk to somebody about it. Also, if you've had losses, if you've had more than two pregnancy losses happen all the time and people don't talk about it. So we don't really even know how common it is. 50% of women may experience a loss. It's really common. But if it's happened more than once, definitely deserves to talk to somebody about it. And then the other big time to talk to me is if you aren't trying to have a baby, but you want to have a baby in the future and you want to see what kind of testing and what kind of options you have now. So whenever I'm like out and, people ask me, what do you do? I say, I'm a fertility doctor. First question I get all the time, what's the best age to freeze eggs? Okay. And it's a nuanced answer. It's an individual answer. So everybody's going to come with it with different history, different fertility goals. So it really is an individual answer. But overall, when people ask me, when should I be freezing my eggs? I say, I want you by the age of 35 to either be trying to have a baby or freezing your eggs for the future if fertility is important for you. Now, age matters so much in this. And so the graphs here are kind of just showing you as you get older, our number of eggs are going to go down and the quality of the eggs are going to go down too. Men, they have it so much differently where they replenish their sperm every 70 days. So the quality of the sperm and the quantity of the sperm is not really declining like it is for females. So females are the ones that really feel that biologic age clock there. So the best time to freeze your eggs is the younger you are, the more eggs we'll get and the higher quality they'll be. So I really think the sweet spot for freezing your eggs are probably in your later 20s and early 30s if you're not trying to have a baby at that point. But that doesn't mean that you can't freeze your eggs when you're older either. Even after the age of 35, you can still freeze your eggs. Just sometimes we're going to get less eggs and the quality of the eggs might be lower. So it is something that we'll talk about potentially doing more than one cycle as well. Now, I think if you're asking the question, when's the best age to freeze eggs? I feel like that deserves a conversation with somebody to talk about your fertility goals and what your history is. And so I get a lot of consults when people come in, they say, I want my fertility tested. So what does that mean? Like, what is fertility testing? What does it tell us? What doesn't it tell us? So the biggest fertility testing that we really have, one of the biggest things is blood work, and one of the levels is called an AMH, anti-Müllerian hormone. It comes from follicles, and follicles are in your ovaries where we get the eggs from. So if you have a lot of follicles, that'll mean a lot of eggs and a lot of AMH. If you have a lower number of eggs, that means a lower number of follicles and a lower AMH. So it's one of the best fertility testing because it's blood work that we could do at any time in your cycle, and we can give you a number and says, okay, this is your AMH compared, and this is what it is compared to other women your age. Is it normal? Is it above average? Is it below average? How does the quantity of eggs that you have compared to other women your age? Now, the biggest thing to remember about that, it's talking about quantity and not quality. Your quality is going to be based on your age. So just by hearing how old you are, I can tell you more about the quality of your egg than any actual test can. So age matters and AMH matters for quantity there. Now, I go back and forth whether I feel like all GYNs should be testing an AMH every year on everybody, because it's an important part of your fertility, but it also doesn't tell me if you're going to get pregnant. So on the screen, this graph is a study that looked at women who have high AMHs, if they have what's considered a normal AMH or a low AMH. And what I want you to get from it is the lines are the same, okay? So even if your AMH is low, that doesn't mean you're going to have a hard time getting pregnant. So I feel like if I tested everyone AMH level who wasn't trying to get pregnant, I'd probably incite mass panic, because if your number is low, everyone tends to freak out. But remember, it doesn't actually predict if you can get pregnant. Because to get pregnant, you need to release an egg. So if you have a regular period, I kind of know already you're likely releasing an egg every month. And that quality of your egg is going to be based on your age. So even if you have a low number of eggs, as long as you're releasing an egg every month, based on your age, if you have a good quality egg, your chance of getting pregnant is the same as somebody else, the same as your age. So AMH is a good fertility test, but it doesn't predict your chance of getting pregnant. It is, though, a really, really important test to me when I'm talking to somebody about freezing their eggs. Because what it's telling me is how many eggs that you potentially have. Are you a candidate to freeze your eggs? If you're a candidate, how am I going to dose the medications to freeze your eggs? If we freeze your eggs, how many eggs could I expect to get? Should we be expecting to do multiple egg freezing cycles to get more eggs to increases the chances of you having a baby? So it's a really important test that I think does help kind of shape our decision about freezing our eggs. But just remember, it doesn't tell me if you're going to be able to get pregnant or not. When you come in, if you are trying to get pregnant and you're having issues, other fertility testing we want to look at all the components we need to get pregnant. So to get pregnant, we need the sperm, we need fallopian tubes, that's where the egg and sperm meet. We need a uterus, that's where they're going to implant. So when we're talking about fertility testing, we want to do something to look at all these different aspects. For the sperm, the best test is a sperm analysis. And so for that, usually partners produce a sample at home, bring it in a sterile cup. Our andrologist will look at it. They'll look to see how many sperm, is it moving forward? What's the shape of the sperm? That gives us the most information about the sperm. We've talked about the eggs and measuring your AMH level to look at the number of eggs. The quality of the eggs is going to be based on your age. Other things you need to get pregnant: open fallopian tubes. Usually we recommend doing a test that's called an HSG, or a histosalpingogram. This is where they put dye inside the uterus and they take an x-ray and they look to see, did it come out of the fallopian tubes? And if it did, we know those fallopian tubes are open. Also going to take a good look at the uterus too, to look to see, is there any fibroids or different shapes of the uterus that could make it harder to get pregnant? And so that's kind of your basic fertility testing, looking at your eggs, your sperm, fallopian tubes, and uterus. The other testing that I recommend all couples do when you're trying to have a baby is do what's called expanded genetic carrier screening, which is a really long word or long phrase. What it is, it's looking to see, do you and your partner carry any of the same genetic variants that would place a child at risk for a genetic disease? Because what happens is there's a lot of genetic diseases that you need to have two genes to actually have symptoms and have a disease. So there's things like sickle cell, cystic fibrosis, the list of like 400 different things that we typically look for. And the idea is you could be walking around with one gene and you are totally fine. You have no symptoms. It's only if your partner was to have that exact same variant and now you have a child together, and that child inherits one gene from mom for cystic fibrosis, one gene from dad for cystic fibrosis. Now, if there's two genes, now that child could actually have the disease. So I think it's a really good test to let you know, does me and my partner have an increased risk for any of these genetic diseases? And if you do, then you have the option of doing testing like testing embryos through IVF, or once you're pregnant, test the pregnancy and the child and things like that. So it just gives you information from there. And when we're talking about egg freezing, also what comes into conversation a lot is sometimes embryo freezing too. So sometimes you might be in a long-term relationship, but you're not ready to have a child. Instead of freezing eggs, and my colleague, Dr. Brady, will talk to you more about freezing embryos too, that's also an option. And so it's always good to be doing this carrier screening testing beforehand, so we know, should we be testing our embryos for any genes that could place a child at an increased risk for genetic disease. So that's kind of the basic fertility testing. Lastly, I just wanted to dispel a couple fertility myths that I hear a lot, just to make sure we've covered it. You do not have to wait a year to seek help from a fertility specialist. Age matters so much that if you're over 35, come after 6 months, or over 40, come to see me. If you're thinking about freezing in eggs, freezing embryos, other reasons to see doctors like a fertility specialist, but also just if your periods are irregular or you have any concerns about your fertility based on your history. If you're under 35, a myth is you won't have fertility issues. Definitely, many women have issues even under the age of 35. 1 in 8 women have infertility, so it's actually much more common. And it's also not always the woman's fault, at least a third of the time, and probably more. It's also the male factor in there too. So it's really important to have a partner involved. When you come talk to a specialist, it's not like we're always going to say you need to do IVF. There are other treatments out there like timed intercourse, IUI cycles, preservation things. It's not just all about IVF. And if you go through IVF or freeze your eggs, you don't need to worry that this is going to affect your future fertility. We're not taking away future eggs. We're really just rescuing the eggs that die off that month anyways. And Dr. Brady was going to talk more about egg freezing and the process of IVF, but just realize we're not affecting your future fertility. We're just preserving what you have now. And lastly, if you just relax, it will happen. Not great advice either. Catherine Monk is going to talk to you about how much stress is really involved in this process, but just remember, stress is not causing your infertility either. So I think it's really worth a huge conversation about stress, infertility, and how they go hand in hand. But just remember, it is not the stress that's making you not get pregnant. All right, thanks, guys. And I'll look forward to taking all your questions at the end and be there for the question and answers at the end.
Jenna, thanks very much. That was great to get a refresher on all of the testing options, and thank you for doing such a great job, and telling us about all the myths that are out there. We hear those, just relax and it'll be okay. How often do women hear that? So very important message for women on the webinar this afternoon. So our second speaker is Jenna's colleague, Paula Brady. And Paula was a medical student at Columbia, and then she went to Harvard for her residency and her reproductive endocrinology training also at Harvard. And we were delighted to have her return home to Columbia a few years ago, where she now has a very active practice. She runs our fellowship program in reproductive endocrinology and infertility. And she also runs our oncofertility program, which is a special program for couples that are affected with cancer who want to think about their fertility. Paula, thanks so much for all you do. You and Jenna make us proud every day in our infertility space and fertility space, and look forward to your talk on the overview of fertility treatment options. Thank you.
Thank you so much, Dr. Dalton, for that introduction. And I'm happy to be here. Information is definitely power in this realm. So I'm going to tear through a ton of information and then answer some questions at the end. So I'm just going to pull this up here. And so let's see, just to get started here, don't want to waste any time. I'm going to just follow up Dr. Turocy's talk by saying a little bit more about the technical aspects of egg freezing, and then we'll talk about the other fertility treatment options for all the variety of reasons that folks could be seeing us. And then I'll just finish up with a few words about fertility preservation for cancer, which is, we never want anyone to need this, but it is available, and just to be aware of it. So just, in talking about freezing eggs, as Dr. Turocy said, the decision is personal. A lot of folks are delaying their childbearing based on career or other things, or if folks have conditions or treatments that could affect their fertility. So potentially things like endometriosis, which we can talk more about, and specifically, chemotherapy or ovarian surgeries that could affect future fertility. And this kind of says the same thing again. Why freeze eggs? So I kind of explain it this way, that we're born with our lifetime supply of eggs. We don't make more, and that number changes gradually over time. What's a bigger issue, as Dr. Turocy emphasized, and it is the main issue, is that the quality of our eggs changes past the mid-30s. So the embryos that we make from frozen eggs are progressively less likely to be genetically normal the older we are when we've frozen our eggs. And so the earlier the better. Before age 35 is definitely optimal. We don't always get there, or, before age 35, or relationships change. So there isn't a strict cutoff for the age to do this, but generally less than 40 is definitely preferable. The earlier folks are when they freeze eggs, the less likely they are to ultimately need them. So it's a balancing act, and patients will be paying storage on frozen eggs for all those years. So it's definitely, there are financial considerations and all of that. Just a word about freezing eggs versus embryos. Embryos are fertilized eggs. So patients will go through this process, retrieve the eggs, they're fertilized with sperm. They can be genetically tested and frozen that way. Embryos are a little bit more stable in the freezer, in storage. And you can do genetic testing of embryos and not of eggs. So for folks who want to know a more concrete number about the viability of what they have in the freezer, embryos is a good way to go. But the difference in thaw survival or stability in the freezer is marginal. So if a patient doesn't have a partner, we're not going to go looking for donor sperm at that point just in order to freeze embryos, because once an egg is fertilized, you can't undo that. So freezing as eggs gives patients options in the future in terms of, what sperm source they'll use. The major point here is that embryos, once they've been combined with a partner's sperm, another individual sperm, that is now a shared legal asset. So if couples separate in the future or disagree, those embryos are going to be caught in legal limbo forever. So if there's any question about the stability of a relationship, or, partners being on the same page, definitely freeze eggs. In terms of egg freezing, the process takes about 2 weeks, big picture. The goal is to suppress your own hormone production and to recruit eggs to grow using injectable hormones, to retrieve those eggs from the ovaries, and to freeze and store eggs in the lab. So conventionally, cycles will start on the second or third day of a period. So patients are still bleeding when we're seeing them in the office to start, or when stopping birth control. There are other ways to do it. You don't strictly have to start after a period starts, but conventionally, this is how cycles are timed. Gonadotropins, which are concentrated versions of hormones your brain makes naturally, just more of it. Those are injected subcutaneously, so using a very small needle like insulin-dependent diabetics use. A few injections daily for about 8 to 10 nights to recruit multiple eggs. We use a secondary medication to prevent premature ovulation of those eggs, because if patients ovulate, then the eggs are lost, they can't be retrieved. And then we monitor with blood work and ultrasound. So this picture here shows a monitoring ultrasound with follicles, which are the cyst-like appearance of growing eggs. So we're counting and measuring those every time folks are coming in, and that lets us know when to set patients up for an egg retrieval. Side effects of ovarian stimulation, the most common are bloating and fatigue, but folks are going to work as usual, kind of doing their usual stuff. With these following caveats, we ask patients not to have intercourse during the cycle because the ovaries are right next to the vagina and we just don't want any bruising or jostling of those growing follicles. We ask patients to limit exercise. You can't really travel during a cycle because we have to see a lot. We ask patients to avoid alcohol primarily because it's dehydrating and the medications are also dehydrating. So we don't want to compound that. And we just recommend that patients rest and hydrate, particularly with electrolytes. But patients are not on bed rest. They're kind of otherwise going about their normal life. The risks are ovarian hyperstimulation, which is when essentially too many eggs grow and patients can retain a lot of water. Thankfully, due to modifications of stimulation protocols and medication selection, we can pretty much avoid any real dangerous OHSS, ovarian hyperstimulation. Everyone who does a cycle gets mild OHSS, bloated, ovaries are enlarged, but it doesn't generally go beyond that with a well-designed protocol. This is the egg retrieval. So it's done in our offices in ambulatory setting. It takes about 15 minutes. Patients get medication in the IV so that they're totally asleep and comfortable. And then we use an ultrasound guided needle through the vagina to retrieve the eggs from the ovaries. So there's no incisions or stitches. It's just a needle puncture, very low risk procedure, very low risk of infection or bleeding. Occasionally we won't get eggs. It's mostly in folks who've had a very low response, meaning only a few follicles grew, and very, very low risk for torsion, which is an enlarged ovary twisting. That is rare. Frozen eggs, they are stable indefinitely. They can be frozen for years. They don't decline in quality. You want to freeze them at a good long-standing center. And if you move, you can coordinate care and make embryos and come back to us for an embryo transfer. You could ship frozen eggs. There's some small risk of moving eggs between labs, like in transport if something happens with the cryo container. If you want to use frozen eggs, it depends. It depends the age you are when you're ready to start building your family. We often recommend trying first to try to preserve this additional resource, but it depends on how many kids you want and the age you are when you're starting. The steps moving forward be to thaw the eggs, inject them with sperm, grow them into embryos, and then you have the option of embryo testing, which would test the chromosomes, which is the overall amount of DNA. It will pick up things like Down syndrome, which is an extra chromosome 21. It'll also tell you embryo sex. So this testing is the only way to know the sex of embryos. You can test for specific genes if parents are already known to carry a gene that you want to test for. So for instance, BRCA, like a breast cancer risk gene, you can test embryos for that if one of the parents is known to carry it. So just in general, how many eggs do we want to freeze? The live birth rate per egg is about 5 to 12%. So once we know how many eggs we have frozen, we multiply that by 5 to 12%, and that gives us our sort of estimated live birth rate. The older patients are when freezing eggs, the lower the likelihood per egg that we'll have a live birth. Rough rule of thumb, which doesn't cover the nuances of specific age, but we want to have about 20 eggs frozen. That would be great, but the average per cycle is about 8 to 10. Even with max dose medications, there's a limit to what the ovary can produce in a month. So many patients will elect to do more than one cycle for this reason. It just depends on your goals, how many kids you want, how likely you are to use these eggs. It's a discussion with your doctor. The 5 to 12% per egg catches most folks off guard. And this is just a quick view of why that number isn't higher per egg. So, we get a certain number of eggs. They have to survive the thawing process. Generally about 90% will, but there can be natural variability each of these steps. They have to fertilize when injected with sperm. They have to grow into embryos. Those embryos have to be genetically normal, which depends on age. And then that embryo has to implant and make a pregnancy. So working backwards, it's about 5 to 12% per egg. The older we are, the more eggs we need frozen. This was a very important study that kind of showed the older we are along this color bar, the more eggs we need to get to a probability of live birth. So, at age 44, freezing 100 eggs will get patients maybe a 50-50 chance of having a baby, versus at, age less than 35, even 10 eggs will give patients about a 70% chance. So it just gives you a sense of the effects of age. I'm really running over my time. So, moderators, feel free to cut me off. I'm going to tear through this last part and then we can share our slides, and you're all welcome to review and ask us any questions. In terms of treatment for infertility or folks who need intervention in order to conceive, which includes donor gametes, donor sperm for single parents by choice or female same-sex couples or any same-sex couple, these are the options. Some patients will try longer. The younger patients are, the more that is a viable way to go. There's ovulation induction with pills or the same injectable medications as IVF, with or without an insemination, and then IVF. Easy things to work on. For heterosexual couples, make sure that intercourse is timed correctly. So 2 days before ovulation, they recommend using urine ovulation predictor kits, particularly Clear Blue Easy is a good, easy to understand kind of kit. Work on having a normal body weight, not too low or too high. No smoking, social alcohol, not to excess, limiting to about 2 cups of coffee a day, no drugs, and solvents and toxins, like folks who work in nail salons, for instance, with those solvents, that can be a negative factor. We'll share this chart with you. There's so much information here, but it's essentially to say that for most kind of reasons that folks are seeing us, there are a range of options. And it just sort of depends on how aggressive patients want to be and their age at the time of treatment. There's lots of causes of infertility, and of course, the treatment will be targeted towards that cause. The oral medications, basically it's oral pills taken for a few days at the start of a menstrual cycle, either to induce ovulation in folks who aren't ovulating on their own, or to induce ovulatory women to release extra eggs, to increase their odds that pregnancy will occur. The oral medications are gentler, so the success rates reflect that. For folks who were getting regular periods going into this, fertility is unexplained, about a third of patients will conceive with these oral meds. For folks who weren't getting periods, most commonly being PCOS, more than half will conceive with these oral meds. And we may or may not combine this with an insemination, which is we basically process a sperm sample in the lab, which kind of optimizes and concentrates it, and then introduce it directly into the uterus with a little catheter. Feels like a pap smear, no anesthesia. It's particularly helpful for mild male factor, where the sperm processing will help the sample, male sexual dysfunction, also female sexual dysfunction like pelvic pain or pelvic floor dysfunction that doesn't allow for intercourse, and for donor sperm. And IUIs are usually not necessary, particularly in women who just need their ovulation induced. If the semen analysis is fine, you don't necessarily need an IUI for that. All right, cut me off at any time, Hope and other moderators. I'm just going to keep tearing through here. I'm almost there. So for IVF, we left off with the egg freezing just to finish out the process. For folks who are looking to make embryos or trying to conceive now, essentially we retrieve eggs, we fertilize them when they're retrieved. There are different ways to fertilize eggs. It kind of depends on the semen analysis. Embryos grow in the lab to become from 1 cell to several hundred cells, with the option of genetic testing at that point. And I kind of mentioned there's general genetic testing for chromosomes, which is just how DNA is arranged in our cells. The older we are, the more likely we are to have chromosomal issues in eggs or embryos. So that's often an age-related recommendation. And it'll tell us embryo sex, which is chromosomally determined. I see a lot of patients who know that they carry a cancer susceptibility gene like BRCA or Lynch syndrome, and you can test embryos for that, which is called PGTM. So that is also an option. The embryo transfer is a lot like an IUI. No anesthesia, a thin catheter deposits an embryo into the uterus, and then we give patients progesterone as an added boost, kind of just to be safe. Risks of IVF, we kind of discussed the retrieval risks. Multiple pregnancy is a common association with IVF, but actually the field is moving towards single embryo transfer, which has a very low risk of twins. Twins are a higher risk pregnancy, Dr. Dalton can tell you, as a high risk OB. So we really aim for one healthy baby at a time. And we do that with transferring one embryo at a time. There's some association with IVF with early delivery. A lot of that's confounded by the high rate of twins that we used to cause. There may still be a little bit of an association. Birth defects, really good studies show that it's most likely related to underlying infertility, which is a medical condition. And so it has ramifications. So folks with infertility, whether they conceive with IVF or not, have this slightly higher risk. There's no association of these therapies with breast or ovarian cancer. What the studies missed in the early ones that kind of associated IVF with breast and ovarian cancer is that infertility in itself is a risk factor for GYN and breast cancers. So it's whether or not folks did IVF, there's a little bit of a higher risk. So that's where that kind of association comes from, but it's not causation. And IVF is expensive. A lot of insurances are covering it. A lot of companies are providing stipends, but it can be expensive. Quick word about outcomes, very tightly tied to age. So again, we sound like, you know, I don't know, tape stuck on repeat, but it really is about age. And this chart here basically shows live birth rate per embryo transfer, per cycle, and total in treatment. And, you know, at this end here, just speaks to the fact that IVF is an amazing technology. It's come a long way. We have not, as a field, found ways to change egg quality. And these IVF success rates reflect that. So just something to be aware of in entering into IVF. All of that I just said. Real quick, fertility preservation for cancer, just for you to be aware, for yourselves and your loved ones. You know, cancer is not unusual in the reproductive years, particularly breast cancer. There's a rising rate of GI cancers, so colonoscopies are recommended to start at age 45. But in anyone diagnosed with cancer, they should be referred for fertility preservation counseling, regardless of prognosis. And just discussing fertility preservation improves sense of well-being. For men, it's a little easier. They can freeze sperm, but you know, I see female patients for this every day. Cancer treatments can affect egg supply, can sometimes induce menopause, which means no more eggs, no more menstrual cycles. And some folks have to, once they've been diagnosed with cancer, they have to wait a few years before they can try to be pregnant, and egg quality and numbers are changing in that time. So these are kind of the options. I don't really have time to go into it, but just to say that there are a lot of
Paula. I think
options.
we don't.
I'm done.
Yeah.
I'm done. Yay!
Okay, you're done. Excellent. Well, we were on the same page because certainly it's a big passion of Paula's, oncofertility, but certainly there's a lot of the whole field to itself, and now there's hope for patients with cancer and who are concerned about it. So Paula, thank you, and Jenna, very much for giving us, you know, such a phenomenal education on testing and the various options. And now I'm going to pass it off to Catherine, Dr. Catherine Monk, who's the Vagelos Professor of Obstetrics and Gynecology and the first person to start mental health at OBGYN. And in a few short years with us, she's just created a phenomenal service to our patients and to many others across the medical center. Catherine has been continuously funded from NIH. She does amazing research, and she is extremely well sought of as a speaker. And she's going to talk to us about how to preserve mental health as you're dealing with the worries of infertility. And Catherine, thanks very much for all you do.
Got to unmute myself first. You'd think after all these years on Zoom. Thank you for such a great introduction and amazing talks from my colleagues. So I too am going to speed through some slides, and we really look forward to your questions. So without any further ado, going right into mental health. So fertility treatment can be stressful. That's probably stating the obvious. And you know, those who are younger and really engaged in fertility treatment to preserve eggs, some of this won't apply, some of it will, but a lot of the stressors come in the context of facing challenges with fertility and how stressful these procedures can be. But pretty much for anyone undergoing these procedures, the time commitments are stressful, the medical procedures themselves just can be stressful, daily injections can be stressful. I have a very collegial debate with my colleagues, because there is some evidence, and certainly what I hear from some patients, they do find that some of the hormones that are related to these treatments shift their moods a bit. I think probably it lands where some people are particularly sensitive, and we're going to learn more about who those people are someday through research. But as we get more into people who are experiencing infertility and going through these treatments, there can really be an isolation from disappointment in their current support network, or really just having a preference for privacy, but then being without people, their typical support network for sharing and getting some validation for all they're going through. It is just tremendously difficult to feel this lack of control for a deeply wanted goal, such as starting a family. And I think that can particularly ring true for many of us who either were raised in New York or gravitated here. We're rather type A, and we like to make things happen. And it can be really hard to be facing this sense of just impotence, in a sense, from wanting this goal. There can be couple conflict if there's a couple in the context of infertility. And just to say, a recent study came out with the levels of stress, being overwhelmed going through fertility treatment, as put it at 79%. So really everybody, or most, are really feeling some of these negative experiences. And so then fertility treatment can be associated with really frank mental health conditions. And so there's some vagueness in the data here, but if we look at prevalence of psychiatric disorders among infertile women, now this is not clear whether they're in treatment or have been told that or feel that it's not possible for them ever to conceive and carry a baby to term, but major depressive disorder was put at 23%, which is very high, generalized anxiety disorder at 13%. And then for these so-called infertile women but undergoing IVF, so there's more clarity on the population here, the depression was at 11%, which is still high. And then here's another, I think, better done study in some ways, but looking at the prevalence of these disorders prior to ART, so assisted reproductive technology. So people are about to begin, so presumably experiencing infertility and the stressors and frustration. So overall, 42% actually reach criteria for a psychiatric disorder, major depressive disorder at 17%, generalized anxiety disorder at 23%. So there's a lot of emotional struggling, psychological struggling, and we would say, psychiatric morbidity associated with ART. So in our department, really thanks to Mary Dalton's leadership, Dr. Dalton's leadership, and also all my colleagues at the Fertility Center and Dr. Zeb Williams for his leadership, we really collaborate in helping patients psychologically, emotionally, mentally go through fertility treatment. We have a monthly support group that's now led by Jessica Erickson, and we also provide individual treatment, psychopharmacology, psychotherapy is needed. So we have a peer support group that does meet once a month, and it's really a place for community and sharing information. What's developed after years is there's a WhatsApp group that people have joined and then broken off into some subgroups with particular experiences they want to share. But what do we do in the support group? We help with distraction tools. We help with finding ways to create agency in your life when you're lacking agency. So people take up learning a language that they've always wanted to do as both distraction and a place where they can have some control. We do mindfulness stress reduction, help with validation, developing scripts for the different interactions, because people ask why you're not drinking or why don't you have children yet. We help with cognitive reframes. Is there a different way to look at this? And we view all of this as really helping to prevent depression and anxiety conditions and help with that support. So I want to just take a minute to pull back from the fertility, infertility area to just really talk for a minute, though, about mental health in women, because overall, women have much higher rates of major depressive disorder over the lifetime and anxiety disorders compared to men. And you can see the numbers there. It's nearly double. And just, of course, social determinants of health for those who are experiencing lack of resources can exacerbate the risk for mental health conditions across the board for men and women. But to go back to women quickly, why are we more susceptible to these disorders? We have more of the care economy burden a greater emotional stress, balancing paid and unpaid labor, more workforce discrimination, higher rates of abuse and neglect in childhood, sexual and intimate partner violence are higher for us. And of course, the biological changes in puberty, pregnancy, and menopause. And then I just put this title here from a colleague's article because I like it so much. It's basically, unequal depression for unequal work. So we're getting depression at a higher rate because we don't make the same money for the same job. And I just put the citations here in case for all of this work, in case someone wants to see the slides and is interested. Very quickly, I'm going to go through what we offer. We have an integrated mental health program to counteract how difficult it is for people to access mental health care. So only 33% of adults in the US get care for their depression disorder. There's only a cold handoff when they ask for a referral. That's just a name and a number. There are logistic challenges, and there aren't enough providers who accept insurance, and only some can afford to pay out of pocket. So we have this embedded mental health program, psychopharmacology, psychotherapy. I'm going to go through this very quickly to leave time for questions. Just to give you a snapshot, these are results that we're writing up for a paper right now. We get about 20 to 30 referrals a week. Someone has a contact with a mental health provider within 1 week of a referral. People stick with us for about 23 visits and they get what they need. We have an 80% uptake, utilization of services compared to that cold handoff. Here's a number, go call it. Referral to psychiatry, only 22% of people follow up with that. There's something called psychiatry access programs, which I could talk about. They're definitely also helping people utilize and get access to care. So super quickly to end up, for those of you who do want to go on to a family, and I hope you get there, and for those, are in the fertility center and they do get there, we're very focused on preventative work. We have funding from the Bezos Family Foundation, where we have a center for the transition to parenthood. And again, I could go into some of these details, but we're really trying to bring in more supports for providers and also for patients so that the whole person is taken care of. We prevent these mental health issues, and that has two-generation impact, both on the parent generation and the future child. So I'll stop there, and we look forward to discussion.
So I was just reflecting on how lucky I am to work with all of you and to be able to provide be in a department where we can provide so much help to patients. And I say this a lot, but I think about it a lot, that we see women at very vulnerable times in their lives. We see pediatric gynecology. You can imagine how stressful that is. We see teenage pregnancy. We see women trying to get pregnant. We see women who have very high-risk pregnancy. We see cancer, and we see women who are struggling with aging and neurocognitive abnormalities. And as a department, we have to deal with all of that. And just thinking about everything all of you have talked about this afternoon, you really do our service proud, and I feel so proud to work with all of you. There are a few questions in the Q&A, and there's some that came in earlier. And I would just say that there were not very many good things about COVID. You think about the stress we all felt during then. But I would say one of the positives that came out of COVID was the recognition that mental health was so important. And it reduced the stigma on mental health. Mm-hmm. And Catherine talked about the number who were referred from, if you say, well, you look a bit low today or you're depressed, I think you need to see a psychiatrist, and here's somebody I would recommend. The chances of a person making that appointment is very, very low. Whereas if I say, in our department, we have Catherine and her team, and they can provide help to you, and you can get an appointment on Zoom and you'll get it quickly, your chances of pickup of that are very, very high. And then, of course, we've seen such a growth in our infertility programs over the last few years, and having wonderful doctors like Paula and Jenna on this afternoon will give you a flavor. So one of the questions that I saw in there that perhaps wasn't addressed, some of them were the questions that came forward were addressed in your talks, are for you, Jenna, what are the medical issues that affect AMH?
There's a bunch. One of the very common things that we see are women with polycystic ovarian syndrome, which basically means you have a lot of follicles. I always say which PCOS was named something different, not PCOS, but polyfollicular, because it really means lots of follicles. So that is something that we see really high AMH. It's even part now of the definition of PCOS. Also, things in your history, if you've undergone things like chemotherapy, or you are predisposed to having very low number of eggs, and there's different genetic reasons for that. We could see really low AMHs from there too. So reasons that you get low AMHs and high AMHs. The one other big thing that I didn't mention is also just being on birth control. Being on birth control suppresses your ovaries, tells it not to work. So when you've been on birth control for years and years and years, and then we measure an AMH level, it can be 20 to 30% lower than it would be off of birth control. So it's also another question that I get a lot is, if I'm on birth control, when should I stop it? And sometimes you can go right into a cycle on birth control pills, but other times it's really helpful to actually be off of the birth control for at least 3 months to get that AMH back to what its baseline level might be.
Great. One question that I thought we could get through quickly was, there's copies of the slides and materials? And I think we can certainly provide those, and we will have our team at Columbia, and Amy will work with your team at UBS to get the appropriate addresses, or maybe we'll send them to you and you can send them out as needed, so we can easily do that. One question, Paul, I'll ask you is, PCOS, and infertility, can anything be done?
Definitely. That's, a whole consult's worth in itself. And I'll try to not rattle on too long like I did before. But basically, PCOS is a condition. It stands for polycystic ovarian syndrome, but it's a misnomer. There are no cysts on the ovaries. It's just that the brain and the ovary are not communicating well, so women aren't getting regular cycles. Weight control, like keeping weight in a normal range, trying to observe a low carb diet, in that sense, that can often help in itself. That sort of patients are often scared by the diagnosis of PCOS and told they will have infertility, and it's generally very good prognosis and often easily treated with oral medications that can induce ovulation sequentially. So there's no medication that jumpstarts ovulation, but month to month, we can use medications to help women ovulate. And then they're like all their peers, ovulating every month and trying. So it's a combination of lifestyle and medications to kind of get the ovaries going.
Great question, Jenna, for you is, how young is too young to get tested for infertility? We're used to answering the other question, when should I get tested later on, or when should I freeze? But how young is too young? And it's a question from a 23-year-old.
I've tested 23-year-olds. That's really about time. Like, if you have been trying for a year as a 23-year-old, you deserve to be tested for things. If you're talking about just testing your AMH level, you want to know, what am I going to do with that information? And if it's going to change something that you're going to do, if you're going to think about freezing your eggs or something like that, that's a reason to get that kind of fertility testing done. But there's other things like having your regular periods or something that might also want us to do fertility testing too at an earlier age. So we talked a lot about age. Being younger is a good thing, but there is still a lot of issues that can also happen in a 23-year-old too.
And the question for this specific 23-year-old is, they're not planning to have kids for 5 more years. So if you could put that in context, that would be great.
Yeah, so if you're not planning on having kids for 5 more years, I think it's a discussion if you'd want to consider freezing your eggs. Even in 5 years at 28, you still have really good chances of getting pregnant. So it's not necessarily something I would say you have to do, but maybe getting that AMH tested is going to be helpful and kind of inform that decision for you. Also depends on your fertility goals. Some people in New York City, we're looking for 1 child versus some are hoping for over 6, and that can also kind of change things too.
Great. And Catherine, for you, how many patients do you see, like, who are struggling with infertility issues, need actually medication, or how many can be treated with psychotherapy?
Yeah, that's a great question. Most often it's through psychotherapy. Sometimes people really, might want an anti-anxiety for some of the more difficult moments. But I would say probably the majority for us, 60, 70 even, are mainly through psychotherapy and really utilizing the group and the peer support of finding other people going through similar challenges.
Great, thank you. Well, that's very reassuring for patients not to have to take more medication, and support groups can be used effectively in the vast majority of the time. There's a couple of other questions in there, but we're already at 5:56. Let me see if there's one more we could answer. Okay. Any insights for you, Jenna, on testing fertility at home? The
Yeah,
brand Modern Fertility.
that's a great question. And yeah, someone I talked to today said, I'd had my AMH tested at Modern Fertility. And I was like, what is it? And, it's good because it gives you a number. But the thing is, can you interpret that number? So I think those tests are good because I think information is power. So I'm not against Modern Fertility or doing these at-home testing, but you need to do, what are you going to do with that number once you have it? And I do actually think Modern Fertility has like a helpline that you could call and talk to somebody. But I think that's really when it's helpful to at least talk to your GYN about what that number is, because if it comes back as being low, we're all going to be panicked because nobody wants to hear a number is low. But it's also really important to understand what that tells me and what it doesn't tell me. So it's good to do at-home testing, but just make sure you're talking to a physician who can tell you how to interpret that number for you.
And I think there's another one here that's very pertinent to young doctors and young professionals, that given the literature coming out about increased rates of infertility in female physicians, would the potential benefits outweigh the cost risks for a young female physician in training, med school, early residency, to freeze eggs earlier in their career, as opposed to waiting until they see if they encounter infertility when they reach 35? Paula.
Yeah, I mean, the earlier the better, especially for folks who know their career is going to be long, past 35, or if they want multiple children. Increasingly, plans are covering egg freezing, like even for Columbia trainees, one of the trainee plans covers it, which is amazing, and achieved somewhat through trainee advocacy for that. So, I mean, absolutely. If you kind of know that's your path, if you're worried about it, you want kids, at least do the consult to help you decide.
Well, we are at 5:58, folks. This hour went by so fast, and I enjoyed every second and minute of it. And first of all, Amy, thanks very much to you for hosting. Thanks to all of our wonderful doctors and panelists for sharing your expertise this afternoon. I can never hear enough from all of you. Thanks so much to our Women's Healthcare Council for your constant support and advocacy for us and everything you do to help women's health. And whether you're exploring your fertility preservation yourself or you're supporting someone on their journey, I encourage you to reach out to us and to our fertility team and our mental health team, should we be able to help you. And certainly our Columbia organizers who are on this call and organize this Zoom, and Rachel and Maureen and all of our team who are so wonderful behind the scenes making these happen, can be sure to reach out to you, and we can get emails from you, Amy, as well. So Amy, the panelists, the Women's Healthcare Council, and all of you for joining us this evening. We really try and stick to our time. It's 5:59, so we actually have stuck to our time. So have a great evening. Thanks so very, very much for being a part of us, and very much look forward to seeing you at our next event.